As a preface, this is not going to be necessarily a talk just about the neurology of HIV. I will be touching on both neurocognitive disorder and peripheral sensory neuropathy, but this is really a talk that's geared to the intersection of long COVID now, along with HIV and other neuroactive viruses and prolonged syndromes associated with neurovirologic diseases. And I am a neurovirologist by subspecialty training and a general neurologist, and I'm still teaching residents and fellows and medical students at USC Keck School of Medicine in general neurology, where I ran for 30 years the HIV neurology and non-invasive pain program for people living with HIV at USC. But I've been at this for considerably longer. So don't be disappointed. You can still ask questions about neurocognitive disorder and about neuropathy, et cetera, and we will again touch on that. But this is a little bit more to bring us up to date in terms of what we're dealing with now virologically, which is long COVID.
Sorry to keep doing this.
So in terms of the lessons that we should have learned, we've known for over a century that when we're dealing with neuroactive viruses that make people really sick and cause pandemics, that there's significant neurologic disease. And I'd kind of like to take you on a little bit of a journey that explains how I got to be here in some respects, okay? So we know that the Great Flu pandemic, the Spanish flu from 1918 to 1920, grazing into 21, was the last time we had the kind of number of deaths in the millions around the world. And just to look at a little bit about that, and hopefully this will play.
Recording in progress.
So you can see the beds laid out, the bodies being taken. Soldiers dying, how it got back and forth across the world because World War I was taking place. Shortage of medical personnel. Okay, no vaccines, obviously, at that time. Same kind of public health crises with hospital beds being, scarce. Okay, we had some advances in science. Okay. And in 1946, the CDC was preparing for future pandemics and bring us up to date. People were masking back at that time, which is what they had, okay? So, taking us back in terms of HIV, which was the next global virologic crisis, we saw the first cases in 1981, as you know, probably know all of this, and can recite it better than I can. On the West Coast, the first 4 sentinel cases of HIV AIDS were described as pneumocystis pneumonia in young gay men by Dr. Michael Gottlieb, who I've worked with through the years personally, and actually did private practice neurology for his patients. And on the East Coast, with injection drug users and gay men with Kaposi sarcoma, first described by Dr. Alvin Freeman Keene, who I also worked with. I saw my first cases in 1981, and I can remember very distinctly a postal worker who was on the down low, and actually I can remember the nurses having to deal with him. They were all scared. Many of them refused to go into the room. His meals were left outside the door. I had to bring them in. I can remember him having a psychotic break because he had to tell his wife and children that he had AIDS and didn't know how to go about it. So it was a very scary time. By August of 1982, the term from GRID had changed to AIDS. In 83, both Montagnier and Gallo published the first accounts of HIV as the cause of AIDS. By 1995, as you know, we had on the market the first triple combination, including protease inhibitors, antiretroviral therapy. But even those that made it to 1995 who had severe disease in their T cells, for example, did not respond. They were too late. So if you had a handful of T cells left, you had a chance. But if you had basically no T cells and had rampant opportunistic conditions and you couldn't keep ahead of them, by that point, you didn't make it. So this is a picture of Vita Russo and Larry Kramer from ACT UP. I can remember sitting in the room with them at the New York Blood Center with representatives from the CDC, where we were begging the people at New York Blood Center to open up the previously saved specimens of primarily gay men who had unexplained hepatitis and or hepatitis B, and to be able to notify them if we tested the blood, since they gave it experimentally to be used for any number of purposes in the future, and notify them that they were HIV positive, and that they at least needed to come in for prophylactic treatment for Kaposi sarcoma, for pneumocystis pneumonia, primarily for pneumocystis at that time, and we didn't have any preventative for Kaposi sarcoma, although there are antivirals now available since it's human herpes virus 8. And for severe fungal infections, if they had recurrent fungal infections, just get them on the board to get them treated. And for CMV retinitis. So this is where I started. I moved to California after my fellowship in neurovirology at Sloan Kettering after doing neurology at Einstein, where we had already published by 1991 the first cases and review cases on neurology of HIV. So I'd already published those papers personally as first author and as co-author on seizures in HIV, headaches in HIV, with world top experts to this day. And so this is me after a night of being likely up at the hospitals, doing spinal taps in the middle of the night, taking care of people around town in the middle of the night, because we did our own hospital work at that time, and then taking care of people during the daytime. I was the first medical director of the HIV Healthcare Center out of the Gay and Lesbian Center in Los Angeles, which later became Jeffrey Goodman Special Care Clinic. And so here I am, they're looking pretty exhausted and trying to be casual because I'd been wearing a tie most of that time and changed into a sports shirt. So here we went, and I wore both an activist hat as well as the neurologist and doctor's hat. And I'm with my rabbi, Denise Hager, who some of you may know, at the March on Washington for LGBT and HIV/AIDS rights in 1993. My t-shirt says you have the right to not remain silent, okay? So let's talk a little bit about differences and similarities between the H1N1 avian Spanish flu, which, by the way, how many years did it take for the Spanish flu to finally die down? Anybody want to raise their hand or shout it out? I've already put the years. Go ahead. How many years? 3 to 4 years, okay? How many years has it taken for COVID to finally die down in terms of, we're still seeing deaths, by the way, but in terms of us being unmasked in an indoor theater, which, and medical offices just stopped mandatory mask policies in the state of California at the beginning of last month, okay? How many years has it been since the beginning? 3 years. So the same amount of time. And here's the take-home message. Had we had a government and sponsors in the government and not Trump and his cronies, and this is the truth, that's, you know, and even those that were supporting him have stepped aside and said it was wrong, we should have been masking sooner and continued with masking, and it should not have been a political issue. And once the vaccines were ready, those should have been promoted on a much wider basis and not politicized. It might have cut the number of deaths down and hospitalizations, and might have cut the time that it took to reach herd immunity and see what we're seeing now finally dying down by a year. And we're talking hundreds of thousands of deaths that were unnecessary. So that's my political statement here. And as an activist doctor, I have to tell you that. And because it's the truth, it is not politicized here, except when it is scientifically true. So all of these viruses are believed to originate in animals, with the possibility of lab errors being involved, but with animal vectors, and spread to humans who had no group or herd immunity. Okay. While the Spanish flu and COVID-19 are both aerosolized as mode of transmission, which is the most highly contagious method of transmission, HIV is bloodborne and therefore more difficult to get. And it's why, because of current antiretroviral therapies, undetectable is untransmissible. So the lungs, the main organ affected in severe initial COVID-19 SARS-2, and there are severe allergic and/or inflammatory type reactions which cause clotting and blood vessels to not have the ability to bring oxygen to lungs themselves and vital organs throughout the body, including the brain. And so we see the kind of inflammatory clotting in all organ systems associated with COVID. So contrary to the initial short-sighted belief that, oh, it's just a lung disease, and if you're lucky enough, you won't get it, and we'll treat the lung disease. And in fact, those that got initial corticosteroids very early on with their disease process before we had adequate treatment and direct antiviral therapy or immune globulin from those with the actual disease, as we've had at the beginning, and then the vaccines, that if you were lucky enough to get somebody that recognized that this was an inflammatory disease and you got started on corticosteroids in high doses early enough, you might have a better chance of surviving. And that's really what we learned. So this is just from March of this year. Scientific American finally published a major article, cover article, which says that long COVID is a neurologic disease. And frankly, those suffering from prolonged HIV, long-term survivors, like many of us in this room, know that, you know, a little bit of cognitive slowing and neuropathy, along with pain, are the things that we deal with at this point as long-term survivors, okay? So, doesn't take rocket science for me as a neurovirologist to kind of know intuitively from the Spanish flu, the long-term effects of the Spanish flu and even immediate term. I don't know if you remember the movie Awakenings with Robert De Niro, okay? And that was written by somebody that I actually trained under, although he was a brilliant writer. He wasn't particularly a great neurologist, and everybody knows him. Brilliant writer. And unfortunately, a closeted man, Dr. Oliver Sacks, who wrote the Sentinel novel that became Awakenings, but also he worked himself in early stages of Parkinson's. Now, one of the reasons I'm a neurologist is because my great aunt had the flu. Her sister died in childbirth during the Spanish flu pandemic. My grandmother's sister, and then the other sister, my Aunt Nettie, had very bad Parkinson's. She was even operated on by head neurosurgeons at the time who were doing cryosurgery and operated on by the top neurosurgeons in the world, and was left bedbound and just in agony and psychotic in terms of what was going on with rigidity from Parkinson's. So I saw her, and I knew that at a very early age, certainly before age 5, that I was going to be a neurologist, and thought I was going to be doing movement disorders and Parkinson's. But HIV/AIDS came along, and I saw the great need for my input, and that doing neurovirology would mean something that I could do for my own, patients and for the general population that I was taking care of with HIV/AIDS, and in doing gay men's health from the get-go of my medical education through now. So, why is this true? Viruses are small particles, and they can get into the brain because they cross the blood-brain barrier, which does not tend to prevent them from getting in as it does other larger things, including some bacteria, okay? So viruses get in, bad for the brain and spinal cord, which are the central nervous system, okay? Now, there are other ways that the body gets viruses in, and they can actually be facilitated in transport to get across that blood-brain barrier at a greater rate, and then can go in diffusion from areas around the head and neck, which is how nasal, infection gets through back to the trigeminal nerve and quells into the brain back that way, which is why people lose their sense of smell and why there's so much in terms of other things, including headaches that we're going to talk about later, because of how the virus affects the head and neck and spreads passively and by facilitated transport into the brain. Okay. So, as I said, we saw the post-encephalitic Parkinson's with this. We knew and should have known from the beginning, even though HIV was described as Kaposi sarcoma and cystic pneumonia, that it was just a matter of time, and it wasn't that long of a time within the first 2 years that people were dying with significant neurologic diseases from active encephalitis and from the active infection of the brain and spinal cord, causing dementia and causing people to have a spastic weakness in their extremities from spinal cord disease called myelopathy. We also knew that it would be a peripheral nervous system disease too, like all of those severe viruses. Okay. So the deaths here were early on in COVID. So, because I wrote this slide very early on. Okay. So the same kind of pro-inflammatory cytokines that cause inflammation of the nervous system and cause meningitis and encephalitis, meaning infection of the covering of the brain, dura or meninges, which as well as the brain itself. Encephalon is the Greek word for brain, and encephalitis means infection or inflammation of the brain. So the same kind of things, the processes that were causing early on HIV-related brain, spinal cord, and meningeal problems, cause the same kind of problems in people living with COVID. Early on in COVID, infections in the hospitals, the neurologic manifestation. Okay. So this is a COVID stroke picture as compared to the immune reconstitution inflammatory syndrome seen in people living with early HIV, which may have reverted to PML in some cases of people with HIV. And so you can see that we have the iris on the right. You can see the whiteout in the top pictures where brain water looks white. And then you can see a similar but less acute picture in terms of the clouding kind of white matter abnormalities in brains of people living with brain disease and COVID-19. So the COVID-19 stroke pictures are on the left with the kind of more diffuse whiting out in picture C, and you can see the stroke, small strokes in picture A, and then the actual whiteout from iris, which is more pronounced, but it's the same white matter that's getting attacked by the inflammatory conditions causing strokes and causing more marked damage to the connections of the brain, which make us think, feel, and move. So we also know that there are other viral pictures that cause chronic fatigue, namely Epstein-Barr virus, which causes a syndrome which at the beginning was called chronic fatigue and now is referred to as chronic fatigue / myeloencephalomyalgic disease. The most famous person prior to COVID suffering from this is Cher, and she's published a autobiography, stating what she's gone through when she's down with regard to her CFID/ME picture. And we know that immune dysregulation is seen in people with long-term effects from diseases, including HIV, and that the picture of peripheral painful sensory neuropathy is in fact one of these long-term effects. And people living with HIV have chronic fatigue often a lot of the time, in addition to chronic pain syndrome and brain fog. So we see this in HIV, we see this in people with Epstein-Barr and long Epstein-Barr, and we see this clearly in long COVID. So all of these viruses, but in terms of COVID, how does it enter and affect the central nervous system and peripheral nervous system? And as I said, there's direct crossing of the blood-brain barrier, but there's also specific receptors within the olfactory nerve and within the central nervous system to which COVID binds, not unlike CD4 receptors in terms of CCR5 and CCXR4 direct attachment in terms of HIV. There are other places in the nervous system where SARS-2 COVID-19 attaches and affects the nervous system, both starting in olfactory nerves, but also affecting peripheral nerves and the brain itself. Okay, so this slide is meant technically to say that there are many different ways that COVID-19 SARS-2 virus, same thing, can get in and attach itself and attack through the bloodstream and through actual nerves in the head and neck, starting with the olfactory nerve, but also involving hearing nerve and valence nerve, which is the eighth cranial nerve, and trigeminal nerve in terms of facial numbness and or pain, and headache, which is a trigeminal nerve, because they're all in the head and neck area, behind and in the nose, and behind the nose, before the sinuses, and also behind the eyes. So again, we see manifestations of meningoencephalitis, of stroke, of hypoxic or lack of oxygen brain damage from COVID, because people were on ventilators because they couldn't oxygenate their blood, of myelitis and transverse myelitis, which we saw in early HIV before we had adequate treatment, which is why striking early and hard is very important to get on antivirals. But we saw these conditions, the same condition of central nervous system manifestations early on in HIV, the same things in COVID. So again, we saw the anosmia and the tasting abnormalities, which are cranial nerves 1 and cranial nerve 7, which is the facial nerve, but it also codes for taste on the anterior 2/3 of the tongue. The extraocular muscles and pupillary involvement, both in HIV, but again, in COVID with variants and classic presentations of Guillain-Barré syndrome, which is where the body thinks that the coating on the nerves, the myelin, is foreign. We see facial numbness in COVID with its cranial nerve 5, a neurosensory hearing loss, and vertigo as cranial nerve 7, and tinnitus. And I had patients coming to me saying, well, the emergency room doctors told me I was crazy, or there's nothing that wrong with you. And, it'll get better. It's all viral. Instead of paying attention to the fact that they were actually getting hearing loss and having vertigo and tinnitus ringing in the ears because of the direct effect of COVID on the hearing nerve, cranial nerve 8. And so we see both the peripheral and central nervous system manifestations of COVID, not, again, unlike the acute manifestations and early manifestations of HIV and HIV left untreated. So long haul COVID now is what we're seeing as long-term manifestations, whether it's the brain fog that is difficult, whether it's headaches, which are more often likely to be migraine, whether it's persistent abnormalities in taste and smell, whether it's the hearing difficulties, whether it's the peripheral neuropathies that we're seeing the whole range of diseases as long COVID. And the majority of suffering from long COVID is from effects of the central and peripheral nervous system, because that's what viruses do. And long term, including HIV, the way we think, feel, and move is how we are as human beings greatest affected. Okay. So similar, we're seeing again long-term survivors with peripheral sensory neuropathy and HIV. We're seeing some in COVID. But this is the number one reason in HIV that I see people today. They have numbness and tingling that starts in their toes generally and ascends and becomes painful, and maybe with burning, painful, what we call dysesthesias, which is abnormal sensation, including burning, freezing, and electrical feelings. And it affects 60% of people living with HIV, and 40% are symptomatic, meaning they have discomfort and or pain and or difficulty with walking, which they interpret as dizziness or imbalance, but it's really because they don't have the cues going from the feet because the peripheral nerves in the feet are damaged, giving the actual information to the brain of saying where the body is in space. So for example, you get up in the middle of the night, you don't turn the lights on. Some people are at risk for falls, but you're climbing the walls to get to the bathroom to balance yourself. And this is because of the peripheral sensory neuropathy, which is so rampant in long-term survivors with HIV. So we know that it's made worse by previous exposure to denucleosides that were used as antivirals in early treatments for HIV, but since 2005, I haven't seen a new patient put on with knowledge that some people still use these for salvage therapy. But with fluxamsivir, we have not had to use these in terms of salvage therapies. So these were Videx or Xerid primarily. And all chemotherapies, including chemotherapies used today, have some sort of vinca alkaloid base in the standard chemotherapies, not only for lymphomas and leukemias, but for colon cancer, for lung cancer, standard therapies. So if you're getting treated with chemotherapy for any number of cancers, chances are you may develop peripheral neuropathy, which is toxic. It tends to get a little bit better when you take those away. But if you're an HIV patient that gets cancer and needs chemotherapy, you're going to have either a masking of the peripheral neuropathy or worsening of pre-existing painful sensory neuropathy. And comorbidities of diabetes and alcoholism, which are the first two causes of neuropathy and painful neuropathy in the world, HIV being the number 3 cause. If you have these things, you're going to be even worse in terms of having painful sensory neuropathy. Okay, so we test standardly for toxic metabolic and treatable causes of neuropathy, including testing of vitamin B12, folate, thyroid functions, TSH, and T4, which is thyroid stimulating hormone, and thyroxine to look for primarily hypothyroidism and low levels of these vitamins. Syphilis serology, because syphilis mimics peripheral sensory neuropathy. And a hemoglobin A1C to look for diabetes, because if we treat the diabetes, we will lessen the amount of peripheral neuropathy and painful neuropathy. And by the way, these are the same toxic metabolic tests used for treating and assessing any cognitive disorders, including HIV-associated neurocognitive disorders. Avoiding alcohol is important. And usually there's no need for electromyography with nerve conduction velocities because it's such a classic presentation. And we know it's due to HIV and these other comorbidities, that doing the electromyography with nerve conduction velocities, if you present with a shaded stocking deficit, and if it goes above the knees, stocking glove deficit involving the fingertips and hands, that there's no need to run the test that proves it. It is what it is. And if any of you have had the electromyography with nerve conduction velocities for any number of reasons, including a doctor that didn't know that you didn't have to do the test, it's not a comfortable test or set of tests to do. Treatment includes R-alpha lipoic acid, which is proven to be beneficial in diabetic and toxic neuropathies, including alcoholism and chemotherapy-related neuropathies. But in a subset of people living with HIV, supplementing with alpha lipoic acid can make you better. And certainly, even if it doesn't help with the pain, it generally helps over 2 to 3 months because it takes that long for marginal peripheral nerve endings to repair at a microscopic rate to repair. That balance and walking in the dark and walking on uneven surfaces gets better. Okay. We treat for pain with medications. Now, my go-to is pregabalin, preferred over gabapentin because it has better efficacy, and duloxetine, Cymbalta in those that have diabetes, because it's approved for such. And in treating patients who have concomitant insomnia and depression, tricyclics and the duloxetine, and tricyclics in particular in people that have multiple areas of pain, as well as terrible insomnia because they are sedating. So these are the kind of things that you may or may not be tried on. Topical rub-ons, icy hot, or similar medications that have 4% lidocaine patches in some people, and compounded topicals and medical cannabis. Generally high CBD, low THC if you don't want to be stoned. And medical cannabis has been proven to be beneficial in painful sensory neuropathy associated with HIV and in migraineurs. Okay, so take that as it is. Now, while topical capsaicin patch at high dose, this 7% patch, has been shown to be beneficial in a subset of people living with HIV painful sensory neuropathy, because it requires pre-treatment with topical steroids and anesthetic agents, and because it can cause blistering in people who may have already damage to their peripheral circulation, particularly diabetics. The use of capsaicin patch has been really frowned upon and not used very often because it can cause blistering and make pain worse. So HIV-associated neurocognitive disorder, abbreviated HAND. Now, other than minor neurocognitive disorder, MND, abbreviated, which is stage 1 of HAND, few people progress to brain dementia 2 through 5 of HIV-associated neurologic disorders. The higher number going to fulminant, being bedbound, and we're just not seeing that much of, because people are on adequate antiretroviral therapy and have undetectable viral loads. So we're just not seeing that much dementia. Now, as people age, we are seeing further dropout of brain cells and people getting a little bit, more with difficulties in short-term memory and in losing things and short-term memory, but again, not horribly severe. And I'm treating a lot of patients at multiple sites and have access to data from multiple sites, including the multi-center AIDS cohort study where I was a primary investigator for 30 years. So we're just not seeing people getting, fulminantly demented unless they have concomitant Alzheimer's or other progressive neurocognitive disorders. And we are seeing, as people age into their 80s and 90s, having difficulty with memory. But again, it's typical of a concomitant senile dementia Alzheimer's type, which we see in the elderly. And of course, if you have early age onset with or without HIV of a dementing illness, we're going to work you up for actual Alzheimer's disease. And we're getting better at treatments, but I want to go into treatments for those right now. So what do? Obviously, you want to get undetectable because virus is bad for brain. And we do use, in a subset of individuals, low-dose medications such as amphetamine and or methylphenidate, Ritalin derivatives in very low doses. But again, to be cautionary in people who already have difficulties with addiction to methamphetamine, these would be contraindicated. So a subset of individuals, yeah, I have on, if they don't have great insurance, Ritalin 5 milligrams at breakfast and, noon, or I have them on Adderall, again, generally 5 milligrams with breakfast and with lunchtime. And yeah, I have a subset of individuals that have HIV and have true attention deficit disorder that persisted from childhood and were likely on medications when they were in grammar school. So yeah, we use memantine and donepezil when there's a component of Alzheimer's, but these tend not to work very well. In terms of non-standard medication therapies, turns out that in the largest cohort of people living with Alzheimer's and extrapolated to all neurocognitive disorders, turmeric supplementation of 1,500 milligrams twice a day with food, online neurocognitive training, either lumosity.com or Brain HQ, like brainheadquarters.com, that I call Super Jeopardy Fun and Games, and a mind, body, spirit set of exercises such as Tai Chi, Qigong, or slow yoga, Hatha yoga, done 3 times a week, along with the neurocognitive, done for an hour 3 times a week, and has shown to be a benefit in people with actual Alzheimer's, which is why I give my patients with any neurocognitive disorders, including minor neurocognitive disorder associated with HIV, turmeric supplementation, online neurocognitive training, and mind, body, spirit exercises available on YouTube to follow along. And my patients are stabilizing, getting better, even with minor neurocognitive disorder associated with HIV. So let's talk a little bit, and we're going to end with what I treat the majority of people, including brain fog, but headaches and long COVID, which are generally migraine. And people who already had migraine are going to get worse migraines. And I see people who never had migraines get migraines with or without HIV when they get long COVID. And they do respond to the CGRP type drugs, which are calcitonin gene receptor peptide. It turns out that in migraine patients and in long COVID patients, the CGRP receptors are overactive. And when we use medications to block them, which is a newer class of anti-migraine therapies, that patients respond in terms of their headache and brain fog and dizziness that are often associated, and sometimes even the fatigue. And the clinical trials with the injectables, which are Aimovig and Emgality, showed benefit. And so we know that the cytokine storm that's associated with the acute infection and may persist in long COVID, which is not unlike cytokine storm associated with initial HIV infection of the brain, does cause an activation of the CGRP receptors. And these slides just show that there are multiple ways in which these CGRP receptors in and behind the eyes and the nose, in the trigeminal nerve, the feeling nerve in the face and head, are affected, and these are the prime generators of migraine also, okay? And that there are particular proteins that either mimic the CGRP receptors that are in COVID itself, or that they actually ramp up the CGRP receptor mechanism, making headaches more prominent. So there are dual ways in which COVID actually either mimics or turns on these CGRP receptors, which need blocking in order to treat their headaches, associated headaches. And that in particular, rimegepant, Nurtec, which is the only oral medication on the market now to both prevent and treat active migraines to abort or stop them, either taken as needed or every other day as preventative. It's the only medicine that will do both on the market. People don't want injections necessarily, and this can be easily given. And I have a cohort of, and when I did this lecture, I have more patients now, but 20 patients who were referred for the treatment of long COVID related migraines or headaches. Many of these patients were HIV patients because they're seen at DAP Health, which is where I attend most of the time when I'm not at my limited private practice in Palm Springs or up at USC teaching, which is very limited right now. And it turns out that a significant number of patients, and I'm not going to go over the exact number because they're on the slide, did respond to the rimegepant, the Nurtec, taking every other day. And those that took it every other day had also significant relief in long COVID related fatigue, brain fog, and neuropathies. As you remember, Little Glory says, basically, you never guess what happened to me. And she talks about being at the country club and having a great rally, playing ping pong and stepping on the ping pong ball and having to go to the closet. The closet was locked. And, it was a terrible thing, so, and it was ridiculous what she said. And then the scene ends where, if you remember, her parents were going to buy the property next door along with Mame, because they didn't want the cellist, who was Jewish, to buy the property. And ultimately Mame buys the property and donates it in his name, and is going to open up a home for refugee Jewish children. At which point, the property is restricted because it's Darien. And the line is, again, and forgive me if I get it wrong, that Mame says ultimately to the benefactor of her nephew Patrick, who was Uncle Dwight to these guys, and put him in a boarding school and introduce him to these bigots. When they finally leave and the marriage is obviously going to be off, Mame says, I won't let you marry him off to an Aryan from Darien with braces on her brains. And then, but when they say that they're going to open up the Epstein home for refugee Jewish children, all the furniture from Use Ulu goes crazy and they're falling off the furniture at that point, and Mame says jackpot. And so, do we have jackpots for treatment of long COVID? Is Nurtec rimegepant one of those jackpots? Maybe too early to tell, but at least it's pretty strong in our armamentarium, and that we're getting better and better at recognizing, with models like us, people living with HIV, how viruses affect the nervous system. Now I wanted a closing slide up here. This is Paul Monette, a major writer in terms of gay men and AIDS. He actually was my patient. I'm in his book, for those that want to read the pages. And he died because he was one who had no T cells with CMV, encephalitis retinitis. And we'd gotten him through Toxo. I used to say I had one more thing up my sleeve, and I ran out of things up my sleeve, and he didn't respond to protease inhibitors and new experimental therapy and died. And so he says, no one will find the way out of hate and violence unless we do. Go without hate, but now without rage, heal the world. And so we have more and more, epidemics and pandemics. I think down the road in history, we better learn. And that's why I do what I do. And that's why I present these things together with now having to take care of people with long COVID and not just HIV. Any questions?
Hi, Dr. Aronow. We have a question in the chat. This person asked, do you have any thoughts on peripheral neuropathy and mitochondrial damage due to HIV and or HIV meds?
Look, we did a look at protease inhibitors in the multi-center AIDS cohort study. And initially, we looked at everything that was available. Most of the drugs that are available now either were similar to what we used then when we did the look. And because HIV actually correlated with peripheral neuropathy, we couldn't make a statement as to whether or not any of the medications did or did not cause. Although when we tried to look at the data itself, the medications, including those very similar to backbones what we're using now, such as Biktarvy, for example, did not tend to correlate. So only the denucleosides correlated 100%, but none of the others that we're on right now are correlating. So does that mean that you can't get neuropathy or have it worsen from newer medications? I already had somebody on Cabenuva say that their peripheral nerves were, hurting all over, and when we took them off, they got better. It simply means statistically that there is not a majority of people, and that those on a medication don't fall 2 standard deviations away from the mean. But that individually, if you're the one that happens to get it from taking a certain medication, that, yeah, it means something to you, but doesn't affect the majority of people on that medication. So I don't know if I've answered that question. And, the mechanism is not 100% mitochondrial. That's just one thing involved. The vascular supply is crucially another thing in terms of initial inflammatory disease and prolonged lack of circulation at the microvascular level. So if the nerves aren't getting enough blood supply, they're going to be more and more damaged. Okay. And if we can get the microphone to people so that everybody can hear, including those that are zoomed in.
I had 2 quick questions. For many years, it had been said that long-term survivors of HIV actually, their age is like 10 years older than their biological, than their born age. Is that still?
And so one of the things on the slide that I didn't actually say, because I was trying to hurry it up so we're not here all night, is that initially we felt from the looking at the majority of cohorts, such as the MAX and the WISE, Women's Interagency HIV/AIDS study, and looking at the cohort of the neurological AIDS brain bank patients too, which is another large group of patients in which I was an investigator, that 10 years decreased life expectancy, but that's creeping up towards 2 years or less. So as people are living longer and are undetectable in terms of their viremias, we're approaching the standard population in terms of longevity, life expectancy. So we're now looking more like -2 years rather than in 2000, which we would have said -10 years, take 10 years off of their life.
And one more quick thing. I'm not sure if I understood what you said with cognition and or memory when living with HIV, that HIV does not necessarily impact memory and losses, but it's more Alzheimer's issues?
Oh,
Or did I misunderstand?
not exactly. What I said was we're not seeing the dementia that we were seeing early on in HIV/AIDS, and that especially now with people becoming undetectable for a prolonged period of time and truly less than 20 copies, that at most we're seeing HIV-associated neurocognitive disorder, minor neurocognitive disorder, which is stage 1, which is not demented. In order to be demented, you have to have significant diminution of activities of daily living. That means that you can get dressed, kind of bathe yourself, unless you have another disability, fix yourself some food, you know, do standard activities, shop, a little bit of cleaning, that if you can do those things and take care of yourself, you don't meet criteria for dementia. And you can have significant short-term memory difficulties, but if you can manage those things of activities of daily living, you can't be defined as being demented. And so we're not seeing the progression until very late age in people who, and in proportion to the people in the general population that get what is known as senile dementia, Alzheimer's type, which is not pure Alzheimer's, okay?
That was a follow-up to Danny's question. He was asking if people were 10 to years, and that's, biologically. So, and there's some research that came out a few years ago. In fact, I think it was Wise with Beth Jameson, that on a cellular level, this, people are 10 to 14 years old. So I think that's different than the lifespan. And then the lifespan you were talking about, that was in the Max and Wise cohorts of long-term survivors, like
Right.
most of us. Okay, that's
okay. And also when we actually looked at spinal fluid of people who were still living in the brain bank studies, okay, and in terms of the autopsies of people, in terms of actual viremia and changes within the brain of people who actually ended up dying, most of the time in the brain bank coalition, not dying from HIV or an opportunistic condition, but dying from cancer or another life-threatening illness or aging alone.
Dr. Aronow, another question from the Zoom chat. This person asked, when there has been mitochondrial damage during HIV, are there any successes repairing the mitochondria?
Well, again, that's not the entire picture in terms of both neuropathies and rare myopathies associated with HIV. And so what we're looking at in terms of repair right now, it is alpha lipoic acid primarily, that we have data, at least in diabetics and other toxic neuropathies, and in a subset of people living with HIV. The other thing that I would add, that in my patients that also are on statins or who have other memory difficulties along with neuropathies, I will often give them coenzyme Q10 for the same reasons. And that may also have some effect on mitochondrial damage. But that's, again, not the entire picture.
Are you seeing in long-term haulers constant forgetfulness?
Can you, I didn't hear the question, so.
Are you seeing in long-term haulers constant forgetfulness coupled with HIV, long-term HIV and PML?
Can
and
somebody
post-mortem?
rephrase the question, because I'm still not hearing?
He's saying
Are you seeing in long-term haulers constant forgetfulness?
people with long-term COVID. He's calling it long haulers.
Yeah, and my HIV patients with long COVID are not faring worse necessarily. They look like non-HIV patients the same, with the new infection and long-term effects of the COVID infection. So, and they respond like the general population without HIV, especially when they're undetectable in terms of viremia. And I've not seen a resurgence of HIV in people that get long COVID as long as they take their antivirals.
Hi, you said a few things about peripheral neuropathy that are the reason I came here tonight. Why are neurologists today, such as one at Eisenhower, doing nerve conduction studies?
Ken, sorry, I don't know. Here's my indication for nerve conduction velocity and electromyography. If you have, for example, radiculopathy, which may be from a pinched nerve in your neck or low back, and you're going to have surgery, or you need a differentiation between, let's say, a carpal tunnel, which is a focal mononeuropathy, and coming from the neck when you may have a double crush injury or double injury, including cervical spinal disease and nerve disease down the arm, as well as the carpal tunnel median neuropathy at the wrist, then I say, yeah, you need the studies done, especially if there's an intervention, a surgical intervention that will be refined based on those studies. Additionally, if you have a demyelinating polyneuropathy where we actually get weak, and people living with, peripheral sensory neuropathy and pain generally have normal strength, except maybe in their toes, which may have minor weakness, but they're strong otherwise, do not need the electromyography with nerve conduction velocities. In medicine, and this is not a pejorative, if it quacks like a duck and it walks like a duck, it's a duck. People living with HIV who have a progressive shaded stocking to stocking glove deficit with the characteristic dysesthesia is worse at night, in the middle of the night, so much so that the covers and even the sheets, if they rub up against their toes, may wake them up in the middle of the night with pain. That's what it is. And it's been that way since we just first described it, and I was one who first described it in the literature in the mid 1980s, all the way through till today.
Okay, I was also given at least 100 blood tests to rule out diabetes. I was told he was leaning towards carpal tunnel in my hands. I had the carpal tunnel surgery on the left, and it was mild. The surgeon did not recommend the surgery on the right because it was so mild. It wasn't carpal tunnel syndrome. It was HIV-related neuropathy, and it always has been for 29 years now.
Yeah. And, while we can't necessarily make huge repairs, whether or not alpha lipoic acid at 600 to 1200 milligrams a day and or coenzyme Q10 supplementation would be beneficial for you. I offer those to my patients, particularly the ALA, the alpha lipoic acid.
Haven't tried that yet.
Didn't know if he was finishing. Early on, you had a slide with Vito and Larry Kramer and talked about the hepatitis B issue. I wasn't quite clear what you were saying because I had been in the hepatitis B study initially in the early 80s in New York. And then when what wasn't then yet called AIDS started to come along, they brought us back in to study all of our fluids and such
That was
at the time. And that's who did my first HIV test, I guess around 84. So
That's
it wasn't quite clear what you were.
But that's
say.
because we were there arguing at the round table before they actually brought you in, and they started bringing people in, but not in large numbers. People who they could easily contact, but there were thousands of men on that list that were not actively available, that we were arguing they needed to do contact, trace them down, and because the blood was there to test, and we had to do a better job of it. So yeah, they were doing some, but the argument that I can remember being in the room and saying, you're not doing enough to look at all the samples that you've got and get a hold of these men if they're still alive.
Yes, hi. I'd like to drill down just a little bit more about memory and HIV and aging. I had a moment, I don't know, it's about a year ago or more, of some confusion, and so I went to a neurologist. And basically, he said that I have brain shrinkage. So would one say at my age, 65, HIV positive, undetectable, that some small amount of brain shrinkage would happen anyway if I were not HIV? Or is that maybe an indicator? My grandmother had Alzheimer's as well. So I'm trying to still come up with a conclusion. Is there something happening, or is it just normal at age 65, one's brain or everyone's brain shrinks a bit? There's space.
Okay.
I don't know how else to explain it.
And I actually was one of the first to publish on this. So if you look up my name and brain atrophy, and we actually looked at CAT scans before MRI was in vogue, it turns out that mild cerebral atrophy or brain shrinkage doesn't, while it's seen in the majority of people living with HIV without cognitive disorder, does not predict progression towards dementia. And it didn't then when we published the data in very late 1980s. It was presented. And even to this day, HIV conveys to the majority of people a mild atrophy, and then aging above, age 65 conveys some, and then the family history. You have to be aware, but I would say in somebody that presents to me, regardless of HIV, regardless of age, with cognitive complaints that I can verify on my own screening, generally Montreal Cognitive Assessment or mini mental status examination modified, that, and their own history, MRI scan of the brain with volumetrics and measurement of hippocampal size, and then offering them the kind of natural kind of things that I had on the slide and talked about: the turmeric supplementation, online neurocognitive rehabilitation, and a mind-body-spirit set of exercises done regularly. It would be important. And that I wouldn't get too excited. We treat people, not scans. So yes, I get it when you say, I can't remember things the way I used to. And, I'm having some word finding difficulties, or I'm misspeaking. And, particularly if you're already on neuropsychoactive medication that may be sedating to treat pain or what have you, you may slip a little bit there too. That's to be expected. So in my mind, if you do all the natural things that I said to do, which are not hurtful, and you avoid alcohol and, non-necessary neuropsychoactive medication, such as drugs, and if you keep the medical cannabis to the CBD component, which is an anti-inflammatory, you stand a chance of stabilization and or reversal, or not progressing. And that's what I would say to do. And then, in people with severe disease, I investigate for other progressive dementias, primarily Alzheimer's. But, there are other things that we're looking at too. And that's a whole another set of lectures. Did I answer your question? Okay.
You mentioned the MAX study earlier, and there was a neuro sub-study that was done.
Yeah, I was co-investigator for 20 plus years on that, and they're still publishing papers with my name on it as a co-author.
Oh, good. I wonder if you wouldn't mind giving us sort of some highlights of the findings of that study. Might be interesting to people.
it's pretty widespread, so I'd have to get permission from the current principal investigators in order to present, but I do have access to that data. That would be another time.
There anything
Okay.
from the
And the person I work with at UCLA, who was head of that site, has also retired from that site. That's Dr. Eric Miller.
So when it comes to cognitive functioning, just in general aging, you often hear that there's a kind of a raft of medications they tell people to avoid, especially over-the-counter medications, anticholinergics like Benadryl, that a lot of people take both for sleep and for, see right now,
Yeah.
allergies. So could you kind of run through some of those and let us know what people should be thinking about when they're
Anything,
self-medicating?
yeah, anything that's going to make you sleepy is going to slow you down in terms of your cognitive functioning. That includes the antihistamines. So if you're going to use an antihistamine, even the prescribed, your doctor should be using one of the more modern ones that are not as sedating, such as Zyrtec, for example. And you know yourself, if you're not responding very well to any number of medications that your doctors may prescribe, especially those that are psychiatric, that it may not be the right medicine for you, and you've got power. Normally, when I give a medication that may have significant side effects, including neuropsychoactive side effects, I let the patients know. I try to, and I warn them that they may feel this way for a while. Example, when I'm starting pregabalin for pain, I'll let the patients know you may feel high or stoned or intoxicated, and you may not like it for the first couple of weeks. And every time they increase the dose, you may have a few days where you're going to feel that way, but please push through, especially if you're getting pain relief. That's how I kind of couch it to, allow people to know about it, but also try and push through side effects that, I'm going to expect in the majority of people, so that they get the trade-off. And sometimes we're trading off, even when I have to use opioids in patients for chronic pain, and I have a large population of people with painful neuropathy and low back pain and neck pain that I have to use opioids in because we've tried everything else. And I'm judicious but fair. They know that there's a certain trade-off in cognitive abilities and being alert, and that the other dangerous trade-off is constipation, which I have to, fight against. And bowel, habits are very important in people on chronic opioids. But I do use them because I can't leave people, exist in horrible pain. And if that's what works for them, when we've tried everything else, and that's what I use. Okay.
Any more questions?
Well, first of all, thank you for all your commitment and sacrifices through your whole career. We really do appreciate it. And also, I have a friend here who has recently lost the use of his left side with long-term HIV, and he's hoping he can get an appointment with you. Is it hard to do?
No. If you are insured with anything other than an HMO, you can see me at my private office. And if you go to, aronowmd.com on the internet, you can book that way. And my husband, who's my spouse, also is my office manager in the private office. If you're in an HMO, uninsured, or have Medi-Cal, Medicare, we take a private office, by the way, but anybody in those non-insured or poorly insured, what I call, because I think HMOs, for the most part, are not good. We need a universal healthcare system where you get to see anybody you want to see, and it's one insurance and none of these walls of prior authorizations and denials of care. And we're the only, large country in the world that doesn't have that. It's shame on us. And I don't see it happening soon. And I fight every day with the HMOs, who think they have the right way of doing things. But I fight every day in terms of denials of care and prior authorization. Anyway, my husband, who's my office manager in the private practice, Mike is here, Mike Garza. And for those that don't have great insurance or HMOs, you can see me at DAP Health, formerly Desert AIDS Project. AIDS as in, you know, HIV AIDS, which we kind of took the name out of. But nonetheless, it's a good place to get HIV care when you don't have great insurance.
Terrific. If there aren't any other questions, we'd like to thank you very much.
Oh, it's my pleasure. Thank you very much. And at home, thank you for your time and patience, and I hope you enjoyed a little bit.